Welcome to this episode of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. You can also find us on Brattleboro Community Television, our Montpelier Happy Hour Facebook page, Emilie's YouTube channel, and of course, wherever you find your podcasts. I'm your host, Olga Peters, and welcome, Representative Emilie Kornheiser from Brattleboro. How are you?
I am wonderful. How are you, Olga?
I am good. You're looking very well rested now that the session has adjourned. Congratulations. And I want to welcome back to the show Mike Fisher. He is from the Office of the Healthcare Advocate, which is part of Vermont Legal Aid. So welcome, Mike. Thank you for joining us.
Thank you, Olga. Happy to be here.
Well, I'm glad we are doing this show today. And I want our listeners, I know we go geeky, we're going to go very geeky today, and I really want you to hang on because what we're talking about has the potential to alter, shift, change your healthcare premiums. And so we all care about this, and we care about you. So please stay tuned to the end. So Emilie, let's start with you. One reason we're talking about this, and one reason some of this, what we're about to talk about with premiums, has been triggered is because of the latest round of federal stimulus funding. So could you lay the groundwork for listeners, please?
I'm going to do my best. Healthcare finance is incredibly complicated and is very closely guarded by the Healthcare Committee. It's one of those, we've talked before about how some of the committees really try to stay like as insular as possible so as to prevent outside interference by other people who think they know better but don't actually understand it. And the Healthcare Committee is one of those committees that does a very good job with that. And
they might have good reasons too.
And I was about to say, I think they have very good reason because it's one of those issues where because everyone touches it personally, they all think they know better, right? And so I think Mike will do a better job going deeper on the details here, but essentially Vermont structured its health insurance marketplace pre-Obamacare, which was, very early sort of in the network, and created certain pools in order to spread out the costs of insurance and care. And part of doing that and doing that well means making sure that you have pools that are diverse enough that you won't wind up with a pool of a group of folks whose care costs a lot more than another group of folks, because you want to sort of spread the risk out as much as possible. And so the non-personal side of me getting engaged and curious about all of this happened last year when we were looking at some Trump era tax code changes. And almost accidentally, a certain type of insurance was allowed to be sold in our marketplace. And that was essentially like this super, super high deductible, low cost insurance that I think was mostly being sold by our Chamber of Commerce, but I think a few other spots. Is that right, Mike? And so we quite controversially put the kibosh on that because it was going to increase the cost of care for everyone long term. And my understanding is that with a big piece of ARPA and sort of a first stage in what the Biden administration is or is not going to do in order to address the skyrocketing, unsustainable, miserable cost of healthcare in America, is this chunk of money that's going to subsidize the purchase of health insurance, and mostly the private purchase of health insurance on exchanges. And so because of that big old chunk of money that we're getting, and I feel like every episode lately, every sentence I say, every episode starts with, and because of this amazing chunk of change that we've gotten from the feds, we can, and this is another one of those, we're able to separate out the marketplace in a way that is going to lower costs for a greater number of people than might have been possible without this particular chunk of change. So we're going to be able to leverage this money that's for the private exchange in order to lower costs for a few more places.
Mm-hmm.
How was that, Mike? Please correct all of the things I said wrong.
I think really good. And I'll back it up. I'll say it again in my own way. So the story from my perspective is when we really got a good look at the tremendous subsidies that the Biden administration was able to get to us through ARPA, and specifically the tremendous increase in premium tax credits for people who buy insurance not through their employer, directly through Vermont Health Connect. We saw a tremendous opportunity. No longer did we have to worry about the individual group. People who buy insurance out not through their employer tend to be more expensive as a group. There is a higher morbidity in that group. And so a number of years ago when Obamacare first passed, when we were implementing it, we put the individual group and the small group together for exactly the reasons that Emilie said a moment ago. The individual group was in real trouble. It was doing what is affectionately called death spiral. As it gets more expensive, healthier people are less willing to buy it and leave the market, leaving only sick people. And then it makes it more expensive, and the beat goes on, and the spiral goes on.
Gotcha. So sorry, Mike, I just want to be clear. The individual group, so I believe I'm the part of the individual group because I work for an organization that has fewer than, I think the limit's like 25 or 50 people. And so I can buy direct from the exchange. So I believe I fall into this category. I'm not going through my worker at all. It's just me and the exchange.
Yeah, so this doesn't refer to the size of your business. This refers to you get no employer subsidy, no employer sponsored insurance. Your employer doesn't offer you a plan, and you go directly to buy insurance through Vermont Health Connect. So yes.
Okay.
And so for years and years, we've been very frustrated by serious limitations in the subsidies, the premium tax credit subsidies. As a part of the Affordable Care Act, particularly a tremendous cliff at 400% of poverty that was worth tens of thousands of dollars for families. You earn $1 over the cliff and you lose thousands and thousands of dollars of tax credits. Really a damaging cliff. And ARPA did away with that. And I should say, ARPA did away with that for the tax years, for the calendar years 21 and 22. So when we saw that and other additional changes, we came to the legislature and said we should consider separating the markets. And the legislature jumped. I think in a very good way to say, we're going to notwithstand, this is a little bit, I'm sorry, geeky, we're going to notwithstand the law that puts the markets together for calendar year 22. And we're going to let people and tell the carriers to file their rates instead of as one blended rate, individual and small group, as two, as one rate for each of them.
I'm going to do a little interruption here to explain notwithstanding, because we like to teach our listeners small, meaningless details about the legislative process. So you can so sometimes you change a law. There's a law there and you repeal the law or you change the law. But one other thing that we like to do sometimes is notwithstand the law. And that just means that you're going to put that law on hold, hide it in a little box for just a period of time that you're notwithstanding it. And sometimes that just happens for the year or two, and that's sort of in session law. And sometimes you keep on notwithstanding every year. So we've talked before about the property transfer tax and the Housing and Conservation Board. All of that money is supposed to go to the Housing and Conservation Board, but we notwithstand it every single year and never give them the money that someone once won in law. So it's a fun little, like, extra little twist that you can do.
So as you just described, it can certainly be abused, or it can be a way of keeping the laws on the books, because you very well might likely go back to it.
Yes.
In this case, we don't know what the federal government's going to be able to do for 23. And so we need to really entertain the possibility of needing to put the markets back together.
One thing we've been talking about a lot on Ways and Means, though, this year is it's really, really hard to change tax law that way and then change it back again, because people get really mad at you. And so really feeling like, even though the Biden administration did so many of these things just for the year, because that's the only way they could really get it through, it's going to be very, very hard for them to go back on those promises from here.
Oh, that's an interesting point. One thing I'm a little curious about is I'm wondering how all these calendars are going to line up. And I'm wondering, will people be getting these subsidies automatically? Because usually if you want to change your healthcare program, there's a window to do that. What is that, like November, January? But now we're just starting a new fiscal year on July 1st. These funds are new. Like, I'm just kind of wondering how all that will line up so that people will actually get these things.
So that's a great question. This change is in place for tax year 21,
Okay.
the year we're in right now. And it is, and people are eligible for it if they're getting their insurance, again, directly, and they're buying their insurance directly from Vermont Health Connect.
Okay.
So how do people get it then?
Yeah.
And so people might be saying, wait a minute, how come I don't know about this? I think this applies to me. And that's because, guess what? Everything takes too bleeping long to make the IT system work. All kinds of IT systems, but if you haven't heard that Vermont Health Connect is a complicated one, it is. And I actually want to give them some credit. They're making tremendous progress and are on track to have this in place in the next couple of weeks for July 1st. So I don't want to promise anything, because they're the ones who have to test it and make sure it's working well and then announce it, not me. But things look promising from my perspective that it will be in place.
And so is it automatic, or do people have to sign up for it?
So for people who are already in buying insurance through Vermont Health Connect, it will be automatic for them. For people who currently buy directly from Blue Cross or MVP, they are getting they have got notifications. They'll get more notifications that they should consider shifting over to Vermont Health Connect in order to be eligible for the tax credits.
No, if I realize that there are people who buy directly from the insurance companies and not through the exchange.
Yes, quite a few.
And why would someone do that?
Because if you were over the subsidy level and you wanted to deal directly with your insurance company, who maybe had a billing system that worked a little bit better than Vermont Health Connect, you might have done that. And we actually encouraged people to do that just a few years ago. And now we're strongly encouraging people to go back. It's worth thousands and thousands of dollars. It's a tremendous subsidy for people who are eligible for it.
And so then how will this change the experience of folks who get insurance through their employer?
So good question. The ARPA had no direct impact on that population, but because we saw this opportunity, and the legislature recognized it and took action. Thank you, Emily. For next year, right now we are in the middle of a rate filing. The Blue Cross and MVP have proposed rates for 22, and so there are hearings in a few weeks, and I'm going to make arguments that the rates are too high, and the carriers are going to make arguments that the rates are sufficient and not too much. But the proposed rates are noteworthy because we see exactly what we expected to see. And I'll just say what Blue Cross proposed is an increase in their individual group market of 7.8% and a decrease in their small group market of 7.8%. So I'm sorry, I should say 7.9% in the individual and a decrease of 7.8% in the small group. So people are out there thinking, I've talked about this a few times, and I've gotten some angry phone calls afterward of people saying, how come the individual's getting, left behind? I want to just say again, the subsidies available to this group of people who are by as an individual will more than make up for that increase. Essentially it now applies to 8.5% of a family's income as compared to the cost of the benchmark plan. And we think that goes for a family of four, it goes very high. I can't remember the number exactly, $250,000 of income or something like that. Now, lots of families will say, hey, it's worth $3 to me, I'm not going to do anything about it. But lots of families will say, hey, that's worth $300 a month to me. I'm going to do something about it.
I'm really, maybe it's a little bit of an aside, but I'm very interested about how many of the details of ARPA are really expanding the role of government in paying for, to me, what is sort of, I use the term social infrastructure, to families at such a higher financial threshold. And I think it's going to make all the difference in the world for what people's lived experience of affordability is, which I think is very different from, say, the governor's definition of affordability.
So
and I think affordability is something you have talked about before when you talk about your rate negotiations. So I'd love if you want to.
Yeah, I want to call out that while it was a good change, we were able to reduce the rate of growth or even have a decrease this year in the small group. People who get insurance through their employer won't see this kind of, I didn't give the MVP numbers. They're not as good, honestly. And these are proposed numbers that we'll fight about. But ARPA didn't give a direct subsidy to employer-sponsored insurance. We were able to eke something out for this next year, but I guess that's my way around of saying, Emily, there's more work to do.
Yeah. Oh, so much more work to do. And so on some level, we're transferring some of the, are we transferring some of the savings that individuals would get to employer-sponsored healthcare in order to sort of make the entire system a little bit more affordable?
We were able to rate the small group market for their actual experience, which was a significant cost savings for them, and able to not hurt the individual market because of the federal subsidy.
Okay. That makes a lot of sense.
I want to mention just another detail or two about, or maybe just one more detail about ARPA that I think is really important. If you received at least 1 week, if you received any unemployment in the year, ARPA provides for an even more generous subsidy for health insurance.
And how would someone know how to access that?
And so I want to repeat again, this unfortunately doesn't apply to someone who currently has employer-sponsored insurance. It only applies to somebody who, well, they could be uninsured at the moment, or they could be buying directly through the Vermont Health Connect. And the thing that's a little bit awkward about the timing of this discussion is the public messaging about all this has not happened yet because the Vermont Health Connect system's not up and running yet. In the next couple of weeks, we need to be bombarding the public. We need to be sending direct messages to everybody who got unemployment. Now, asking Department of Labor to do something's a little bit tricky today, but Vermont Health Connect needs to take on the job of doing that outreach, making sure people know about a significantly more generous subsidy that will provide for not only lower rates, but also lower out-of-pocket costs.
So you said that most of the savings will happen automatically if someone's already on the exchange, but the exchange doesn't know who was on unemployment and who wasn't. So how would someone who was already purchasing their health insurance on the exchange, collected unemployment for 2 weeks at some point in this last year, how would, once the computer system's up and running, what should that person do?
Well, that person's going to get outreach both through general media and direct. I should say they should, if they do it right. And some of it will happen automatically for people, but sometimes in the example you just gave, people are going to have to take some action on of their own. They're going to have to respond and affirmatively say, I had this.
To the exchange.
Yeah.
Okay, great.
And I got to pause a little bit. I don't want to get ahead of myself. I don't know exactly the rules that are being laid out and whether it's possible. I should say it would be a good thing if they were able to match names between Department of Labor and but I don't know. We don't know exactly how some of these details are going to play out.
I think that they would need legislative permission to match that data.
Oh, interesting.
They might.
And I also don't know if they are.
They may already have it.
Okay, if they already have it, that's great. Otherwise, the IT system of the Department of Labor is, from 1984 and can't export anything. And so I just wanted to make sure, I also know in my community, I talk to a lot of folks who are on unemployment very regularly. And I think a lot of folks have stopped paying any attention to any mail from the Department of Labor at this point because there's so much of it in so many different directions.
Yeah, we
when I was advertising a public hearing, I had to write to people 3 times with more and more personal subject lines. And finally, someone wrote to me, "Oh my goodness, I'm so sorry. I didn't realize it was you and you were a real person and you act, so just want to make sure that we're spreading the word."
I will say just another sentence about this term affordability and sort of call out one of the things that I think healthcare policy folks often miss. We talk about people being insured. We don't talk about people being paying premiums who can't afford to use their care.
Yep.
Yeah.
And more and more over the last number of years, people are buying, the plans include more and more cost sharing. And we hear from people regularly at the Healthcare Advocate's Office, I should make a plug. If there's anything that I've said that makes you go, wow, I need to know how this applies to me. And, I think Mike Fisher might be talking about me and I need to get a better understanding of it. My office runs a helpline that's staffed by 8 incredibly knowledgeable advocates who are available to answer questions. And our phone number is 800-917-7787.
What was that number?
800-917-7787.
And I would like to put in a plug for your plug because I am a huge fan of just the general structure of advocate offices and ombuds offices, because I think that everyone needs a helping hand to work their way through bureaucracy sometimes. But your office, I always feel like whoever I send your way is going to be well taken care of. They'll both get help accessing the system, but I also feel like people then leave understanding the system better so they can advocate better for themselves. And that is just all I want for Vermonters.
Thank you. And I will pass that message on to the people doing the work because they need to hear it. Treating people with respect and fighting for them to help them get what they need is what we do our very best to do. And so, we're talking about insurance and the cost of insurance and the details around ARPA. I want to broaden just a little bit. If there's something else going amiss in your care, If there's a bill that's not being paid and you think it should be paid, you might think it's the insurance company, or you might think it's your provider. It might be the combination of the two. This is a complicated, crazy system we've developed. My office is there to do our best to help.
Thank you.
And if I could, just before, I know we're about to go to the break, Olga.
Well, I was going to say anything else before we go to the break.
I have something. This is very specific to our Windham County audience that, so mostly for radio listeners, I'm saying this, but mammograms are free. They're covered by your insurance, but because of the complicated relationship between Brattleboro Memorial Hospital and Dartmouth Hitchcock, you are going to get a bill for your mammogram and you're going to have to call 3 people and fight about it. And it is worth it. It's a
Yes.
massive disconnect between their computer systems, and they will fix it, and they're happy to fix it. But it is worth your time to call before they send you to collections, because mammograms are free.
Yeah.
Yes, and as someone who got those bills and called Emilie freaking out, it is totally worth the call.
After the first time I freaked out, and now every year I'm like, I know what I have to do to fix this stupid problem.
And I got to give just a detail or two more.
Yes.
Screening mammograms, screening breast imaging is free. It includes ultrasound for screening purposes. For diagnostic purposes, cost sharing and deductibles apply.
Mm-hmm.
And so what that means,
Yeah, it's
is
annoying.
you're going in for your regular checkup, and you have there's no specific event that's making you come in, then it's actually not free, Emilie. We all pay for it through our premiums, but there's no cost sharing. You shouldn't have to reach into your pocket and pay more.
Even if you have really shoddy insurance.
Yeah. So thank you, Emilie. Thank you, Mike. Everybody stay tuned. The Montpelier Happy Hour on WVEW 107.7 LP Brattleboro will be back in a moment. Welcome back to the second half of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. I am your host, Olga Peters, and if you're just joining us, I'm speaking with Representative Emilie Kornheiser and Mike Fisher from the Office of the Healthcare Advocate. Welcome back to the show, folks. I want to dive in on something you touched on before the break, Mike, which were these kind of concepts of affordability and also what it meant to have in light of out-of-pocket expenses. Would you kind of dive back into that for us?
Sure. So there's a term in the world of healthcare that's called underinsured. And it's an attempt at measuring how many people have exactly what you just said, have out-of-pocket exposure that is a relatively high percentage of their income.
Mm-hmm.
And there's actually a real definition of that Vermont has used that I'm not going to attempt to repeat right now, but it's sort of a two-factor, both sort of the potential exposure of deductible that's a high percentage of your income, or actual experience of healthcare charges that are a high percentage of your income. And the Vermont Household Health Insurance Survey is something that Vermont does every 3 years, I think is what the statute says. Emilie, it's been not withstood before, so it's happened I think 4 years one time, but it was done 3 years ago in 2018. And it's being done this summer. And I'm really looking forward to the outcome of that. In 2018, it showed, I think it was 40% of Vermonters who buy private insurance passed this test of unaffordability.
That's sobering.
I want to be careful. I think it was 40% of people below the age of 65 who were not on Medicaid, so it's a pretty high percent of people who pass this definition of unaffordable. Another way of saying it is in 2018, Vermont hospitals reported that there was $85 million of bad debt. That is 85 million Vermont families were unable to pay $85 million of charges. And I'll remind you, that's from the hospitals. Hospitals represent something like 40% of the healthcare dollar. So there's more bad debt, unpaid medical bills to the rest of the healthcare system. And, we've been asking ourselves for a while, what does that number mean? When you if you contextualize that in your community, how many Vermont families experienced an inability to pay their medical bills, and what does that mean for their lives? We hear horror stories, really tragic stories of people who said, I already owed my provider money and didn't go in and didn't get a cancer diagnosed in a timely way and didn't live. I suspect that the more common story is not so extreme, but still, people. Somebody commented to us one time that she fell. She hit her face bad. I think she chipped a tooth. She was in real pain, and her first thought was, "I can't go get care. I can't afford it." And so that's a real experience in Vermont and in the country, despite the tremendous gains we've been able to do that we talked about in the first half. We know this is playing out in Vermont families. My office is going to spend some time this year trying to really collect stories and really understand in a better way, what these big numbers, what does $85 million across Vermont mean in terms of Vermont families, and how does it impact the way people behave when they think, I probably should go get this looked at? How does it affect the behavior?
I think I've talked to parents who control their children's play in certain ways because they can't afford a broken arm. Not because they're, I think most parents kind of feel like broken limbs are like, they're not that concerned about their kid and the pain. It feels like that's sort of the deal with childhood, that you break some bones. But parents just being really significantly concerned that they can't afford the cost of those injuries. And so have their kids take less risks than they might otherwise allow for them because of that.
It's worth recognizing that here in this country, people feel a great deal of embarrassment, a great deal of self, they blame themselves. Imagine the feeling that when you think I can't, I don't know how to afford my kids' care. And part of my intent, and part of the reason to talk about it publicly like this, and part of my intent of doing a study about it, is to really say, no, this is a structural problem.
Yeah.
This is not a poor decision making, for somebody who's unable to pay. Lots and lots of Vermonters are experiencing this.
Absolutely. And I've talked to more and more seniors who are on Medicare but can't afford the supplemental, and so are essentially but aren't eligible for the Medicaid supplemental. And so I'm hearing from more and more seniors who are actually falling through the health insurance cracks too, even though we have, I think, stories about how Medicare meets everyone's needs.
Yeah, no, thank you, Emily. I actually think a very high percentage of that uncompensated care is people who have Medicare and no secondary coverage. And it's a surprisingly high number.
Yeah, and so when people talk about Medicare for all, I like to talk about Medicaid for all, because Medicaid actually is awesome comprehensive service.
Or maybe it's an improved Medicare for all.
The for all part is the really important part.
Yeah, the for all, yes. There was something else about affordability that I'd love to hear a little bit more about that you talked about last time you were on the show, which is when you're doing the rate review process, the way affordability is sort of explored in that context.
Yeah, it's a fight we have every year with the carriers and to some degree with the Green Mountain Care Board. The Green Mountain Care Board has, I think, 5 factors. I'm not going to I don't have them in front of me, but it includes solvency. Is the insurance company able to financially stable enough to pay its bills? Hey, that's important. If I'm paying a premium to Blue Cross, I want them solvent. And then also, are the rates affordable? And those two concepts, depending on how you understand them, could really be in conflict with each other. If in order to have a solvent plan, only Bill Gates and I don't know who else.
Who's the other famous rich person you're going to pull out? Let's say Governor Shumlin, just for fun.
Yeah. Only a handful of very wealthy people can afford it. Hey, that doesn't do any of us any good.
No. So this little bit of a left curveball here.
Yeah.
I'm curious, you talked about structural problems. You talked about the affordability and the solvency. If we were to back this out from focusing strictly on healthcare and how people pay for it, what other levers in Vermont society need to be pulled so that maybe those issues of solvency and affordability were not in so much conflict?
Yeah. Yeah, I think it's a great question, and I go back a little bit to the cliff in the Affordable Care Act that is fixed for this year and next, and we really need to be fixed beyond that. But that cliff at 400% of poverty is it also falls at a place where people lose income tax sensitivity on their household incomes, supports, for college for their kids, a bunch of other supports. And it sort of lines up in a particularly damaging way, for hardworking Vermont families that, on paper might look like they're doing okay, but they're particularly exposed.
Mm-hmm.
We've talked to Deb Brighton a few times, who works with the Joint Fiscal Office and was on the Tax Structure Commission, about the sort of the felt experience of that trough from $30,000 a year to $90,000 a year, and how often for a family, like, the actual extra cash you have on hand barely changes in that huge area because we don't line up all of these subsidies and benefits on top of each other very often and say, how do these all work together to impact a person's life?
The legislature's Joint Fiscal Office does a study every year, the basic needs budget.
Yeah.
And it's a really interesting exercise. I fear a little bit that it was asked for a number of years ago and it's not used too much now. But it's a great deal of work, and it's a very interesting document that exposes exactly what we're talking about.
Yeah. What I always find interesting when I have conversations outside the Montpelier Happy Hour about things like economics and wages and household incomes and taxes and all these things, I'm always amazed at how willing people are to say, well, that's too much, or we should be able to get by with just this. Like, there's always this sense of like, bring the bar down, bring the bar down, bring the bar down. Instead of, as Emilie has said on the show multiple times, we're not actually looking at what things actually cost and what people actually need to meet those costs. And I think that's just a really interesting disconnect I hear in a lot of these conversations around anything financial.
And I think if we could figure out the cost of healthcare a little bit better, then that would really, for businesses that are buying healthcare for employees, that would really free up a lot of dollars to be paid out in wages to people. So there's just one, I think, example of how the system sort of feed each other.
It's a incredibly complex system that is built with a lot of processes that cost a lot of money. Yeah. The way claims are figured out, and the number of people who are focused on the exchange of money, not focused on the care.
So how does
has to be a big part of the answer. Sorry, go ahead.
Right. How does one care fit into all of this?
Oh, good question.
Good question. Hard one to answer. The theory is a really interesting one. If we change the financial incentives for providers, pre-OneCare or pre, value-based payment systems, providers get money by doing, billable hours, billable time procedures. And so some people say, hey, that just drives business and drives money and is not so linked to whether people really need care. I got to pause there and say, I'm a pretty critical guy of our healthcare system. I'm really critical of the financial interests and the way it changes what actually happens. I'm not that negative about our providers. Mm-hmm. I'm pretty negative of some of the, again, the financial systems on top of our providers, but I don't think providers are out there just willy-nilly doing more care. Someone will tell me there's examples. I know it. There are examples. But your average Vermont provider, I'm not quite as negative about that. So that maybe sort of go on to the next statement about what OneCare is trying to do is to change the incentive. So instead of saying, hey, we're going to pay, the provider who's taking care of me, X number of dollars for every bit of care they give me. Instead, we're going to give the provider X number of dollars for the care I need for a year.
It's interesting. I've never thought about it in quite that dark a fashion as you just described. And I've always, I didn't think of it as disincentivizing excessive care, but rather being willing to cover the cost of preventative care, or more systemic care. And that's, but I think that's only done in the way the system's constructed right now. That money's only available if you actually believe that you're removing money from this other stream that you said there's probably I agree with you. I don't think there's actually all that much care to be removed on that other side. So that's interesting.
So many, many years ago, I told the story many times, maybe with you. Many, many years ago, I was at a hospital board meeting. And I was a legislator and I was waiting for my turn and the board was talking and the CFO was saying to the board, I know that our budget doesn't look good right now, but don't worry, we're coming into flu season. So that CFO was saying, hey, there's predictable care that's coming and we're gonna get more revenue and our budget's gonna look better. So just to take that example as a good public health example, imagine, if you will, instead the hospital said, hey, let's do whatever we can to avoid flu this year because we'll make more money if fewer people need to get care. Mm-hmm. It's a simplistic one, but there's plenty of places like that. And it goes directly to your point, Emilie, preventing care, getting care to the people at the right time in order to avoid more expensive care later.
Mm-hmm. So
that's the theory.
Yeah. From your position as a healthcare advocate, Mike, have you seen anything in this past year and a half with the pandemic that either shone lights on things differently, so that, any learning curves or anything you looked at and said, see, this is why we need to do X? Yeah.
I think I got to give another half a sentence or the other side to the theory part before I do that.
Sure.
I'm not sure we've seen evidence yet that it's playing out that way.
Okay.
And it might be that it takes 10 years to see it. But I think that, this is supposed to be a demonstration, an experiment. Mm-hmm. And it might be that the all-payer model efforts will improve quality in some places, improve coordination, improve wraparound care for people who need it. Those are good things. But at least in my mind, the jury's still out as to whether it will save money for the system, let alone save money for Vermont consumers.
Mm-hmm.
On to COVID.
Yes.
Yeah, for sure. COVID has exposed, some of the problems we knew were there, and exposed them in a real way, about, populations that are not getting the care they need, haven't gotten the care they need, are more susceptible to a disease like COVID, or more susceptible to the diseases that cause more problems when you have COVID. Some of that's racial justice. Some of that really is racial justice. We see it in those populations. And then the other thing is, for a year and a half, a lot of people haven't been getting care. They've been avoiding care. And we need to understand what the impacts of that has been. I know there are some disastrous impacts of that, people not getting diagnosed in time. But I also wonder whether that there's some lessons of some of the care that people were getting before that wasn't really needed. It's going to take us a while there's going to be a lot of doctoral theses that are going to be written about this time. But I'm hopeful that we're going to learn some real lessons about, this has just been a big disruption in the status quo, and hopefully we'll learn from it.
Thank you. So, Emilie, I know you need to be heading off to another meeting pretty soon. So we're running low on time, unfortunately. Mike, thank you for joining us today. Emilie, you mentioned a task force that will be meeting this summer. Can you tell us more about that?
Yeah, and I unfortunately did not pull up the language from the budget about the task force before we got on the call today. So I'm sorry about that. But sort of big picture, really near the end of the legislative conversation this session, some language got inserted into the budget on the Senate side. I think pretty with some strong leadership from our pro tem to put together a summer task force to look at the issue of health care affordability and access to healthcare in Vermont, with a real eye towards what is possible with the Biden administration in place. I think and we've probably talked about this before, but I think the felt experience in the legislature of the failure of single payer and sort of the hope and then the dashed hope of single payer is still very, very present. And I think a lot of people still feel very clear that it's not something that Vermont can do on its own. But it's been a long time since that conversation happened in a comprehensive way. And so really revisiting the issue with today's numbers and with a real eye towards both Vermonters' experiences, like, Mike said, that sort of listening project that they're doing, but also with an eye towards what collaboration with the Biden administration might look like to change the conversation here. And so I believe 4 people will be appointed from the House and 4 people will be appointed from the Senate. And I think that's right, maybe it's 3 and 3. And I think that will happen sometime in the next week or 2 and we'll find out who it is. But really looking forward to that group's work. Hopeful to stay engaged, if not appointed on it. And there's some necessary conversations there.
Just to chime in,
yeah,
I'm hopeful that we'll have some new opportunities from the Biden administration. Are we ready for them?
Yeah.
Okay.
And I think the task force is designed to address that question directly. We need to be nimble in a way, ready to respond and frame up a Vermont answer that fits in the framework of where the Biden administration is going. And so I'm very happy to have seen that language make it.
Yeah.
Thank you. Thank you so much. Mike, before we head out, anything you want to leave listeners with?
No, great, wonderful opportunity to have this wide-ranging conversation. I'm always game. Always feel free to reach out to me. I'm happy to speak. Thank you.
Thank you. And the number of your hotline one more time.
800-917-7787. And let me just say, I think I'll try and get a couple of links to the webpage how to make comments about the Green Mountain Care Board's rate review process. That's happening now, and I'll get a short paragraph about timing for that.
Great.
And how to reach us both by phone and also by email or the web.
Fantastic. Thank you. Emilie, any last thoughts before we head out?
I'm grateful for the opportunity to talk about an issue that touches each of our lives so very directly and each of our wallets so directly, and feels so infinitely easily solvable and totally unsolvable all at the same time. Like every other country has figured this out, why can't we? And also like, how are we going to figure this out? So really glad to dive in on it. And
thank you. Yeah. Well, to you, Mike, thank you for joining the show. And thank you to all the healthcare advocates in your office. We will be back next week. Take care, everybody.